Hello there, modern man. In this episode, we have Dr. Doug. He is an orthopedic surgeon and the expert in bone health and probably everything orthopedic. And I'm glad to have him on this show because we're going to dive into why you should care about bone health as a man. And this is not just a problem about women issues. And we're going to see how that is related to your sex life because you will find out a very interesting connection between your bone and your sex life. And we're going to dive all into that today with Dr. Doug. So, welcome, Dr. Doug.
Awesome. Thanks for having me. Looking forward to it.
Okay, so let's just dive into it. So, what is bone health and what happens as we age? Why should we care about bone health?
Yeah, great question. And I'm so glad to get this in front of an audience of men, or at least mostly men, because we don't talk about this with men ever, anywhere. It's never brought up until a man is in his 80s, 90s, and he's had a hip fracture.
Mm.
And we think about bone health or osteoporosis as a woman's problem, women as they go through menopause. And yeah, that's true. But the way that I look at bone health now is that bone health is really a biomarker of health span for all adults. If you're losing bone, something's wrong. And the cool thing about bone is it gives us a clue. It tells us a story because we can use blood testing, we can use imaging, we can tell what's happening in our bones. And it can tell us if we need to look deeper at some of the things that we're going to talk about, like hormone levels or lifestyle or potentially gut health, nutrition, et cetera. So I think that we should all be looking at bone. We should be imaging it in young adults, including men. And then if we're losing bone, looking to figure out why.
Okay, so let's kind of backtrack a little bit. I love what you just said that it's a biomarker for health spans. Essentially, bone health is something you should care about because it's a marker for your health. So, why should young men care about that?
Yeah. So there's, I would say, three main reasons we could go through. One is that we develop our bone as we go through adolescence and childhood and young adulthood. That time period is critical for developing your what's called peak bone mass, or the amount of bone that you're going to have for the rest of your adult life. We don't talk to children about this. I don't really talk to parents about this. To catch adults in their early adult life and say, look, you need to know if you did a good job there or not. And a lot of people didn't for various reasons. They might not have good bone density out of the gate. And that's something that you're going to want to know because it's going to change how you treat yourself and what kind of things you involve yourself in over time. So number one is we need to know peak bone mass because we want to know what we need to do over time. Number two is low bone mass is associated with fracture. Now, again, most people think, oh, hip fracture, hip older people, I don't need to worry about this. Not really true. As a practicing orthopedic surgeon, I can tell you that we see fragility fractures in the younger and younger adult population. I'm talking 60s, 50s, 40s, 30s. And this includes
Mm.
both men and women. I think we're facing an epidemic of poor bone mass that we don't know because we're not screening. But in my orthopedic practice and in my current practice, specializing in osteoporosis reversal, we see young people that either never had good bone mass or lost their bone quickly as they aged and then had a problem very quickly. What sucks about that for men is that we don't know, we're not screened. And if you have a hip fracture, it's life changing or life ending. If you have a spine fracture, it's definitely lifestyle changing, probably not life ending, but it'll change the way that you live your life and it might change your independence. And that's a huge deal. Nobody wants that. And we don't even think about that until we start thinking about older men, 80s, 90s, and above. But it actually is happening much younger. And if you want to prevent fractures later, you need to start younger.
Okay, so why are we seeing more fragile bone in younger men now? What the heck is going on?
Yeah, I look at, again, bone as a biomarker of health span. So when you think about, oh, why would we see bone go down? Well, bone can decrease for a lot of reasons. I would say some big ones at play right now would be poor diet. And these are your same lifestyle pillars. Poor diet, wrong exercise or lack of exercise, poor sleep, which is rampant in our especially young adult culture, and then stress, unmitigated stress, not knowing how to handle stress. Those four lifestyle things are going to have a huge impact on bone health because of excess cortisol, immune system dysfunction, all the things that go along with that are going to affect everything else, including your sex life. But I think in addition to that, what we're not also doing for our young adult men is checking testosterone levels adequately. Every guy should know what their testosterone levels are. They should know total, they should know free. And if they have low testosterone, have a plan to fix it, because the hormone optimization is a huge part of bone health. And one of the main reasons we see people lose bone for is because their hormones aren't optimized.
Okay, so it all come down to hormone. That's one of my passion as well, because that's where we see the intersection between sexual vitality and sexual health with bone now. So you're saying that bone is dependent upon diet and exercise, sleep, and stress, right? Which is kind
Right.
of like the pillars for a lot of conditions. So, and you open up my eyes on like, oh my God, bone health and bone density can correlate with cardiovascular disease, can correlate
Right.
with diabetes, and now your sex life. And so that was a big revelation there. I haven't thought about it honestly like that. So that's why I was very interested in having you on the show to find the connection. So we know, hey, your diet, your exercise, sleep, and stress. And you also said that if you have fragile bone that is not dense, then you're at risk to having fractures where we don't want. And as an orthopedic surgeon, let's just kind of dive into a little bit about fracture. So why
Yeah.
is it not good when you have a fracture in the hip or a fracture in your spine, like in the vertebrae? What are the
Yeah.
kind of like sequela?
Yeah. So when you look at, I mean, most people think of fractures, they think of like a leg fracture and even like a thigh, like the leg bone fracture, the thigh fracture, the femur fracture. And those things heal pretty well. Ankle fractures, assuming they're put together, they heal pretty well. Hip
Mm,
fractures, though, are pretty crummy injuries. They do heal usually, but they don't heal very well. The
mm,
function of the hip joint is very sensitive to alignment of the bone. When we line that thing up on the operating table and we put the instrumentation in, there's really no way to know precisely what that alignment looks like. We put it close, and that's as good as you're going to get. But close, when it comes to function of the hip joint, especially in a younger adult, close isn't good enough. It needs to be perfect. So while there are some surgical things you can do, and there's people that talk about a different type of surgery for young, that's a different discussion. What I'm saying is we want to avoid that pretty much at all costs. We want to know what's happening with our bone density. If we get to the point where we had a hip fracture, you've been losing bone for a long time. So we want to know before that occurs. Spine a little less obvious. So spine happens earlier. Spine is mostly, if you have a spine fracture, it's mostly going to be associated with pain. If you have enough collapse of the bone, you can actually get deformity. You imagine you have that what's called dowager's hump, that hump of their upper back. That's for multiple vertebral fractures. And I've seen this in men in their 40s. They start getting deformity in their spine because they're fracturing. So we want to avoid these things because our skeleton is our structure. And unlike the things that most people think about, wrist, like ankle, some of these things, when they break, they don't go back together very well. So the spine especially doesn't go back together. It sort of stays where it lands.
So, what are the consequences or quality of life changes if you have a hip fracture from
Yeah.
having poor bone health? What does that mean for somebody after they have a hip fracture? I assume that they probably have like a metal in there, an
Right.
internal fixation, right? A metal bar in there rather than a total hip replacement. So, what quality of life changes would they expect to see if they have that procedure?
Yeah, if you look at the overall statistics, if you just generalize this across both men and women, it's actually worse for men. But if you generalize it across men and women, about a third of patients after a hip fracture die within a year. A third lose
What?
independence. Yeah, they lose independence completely. Only a third regain independence. And I can tell you my clinical experience is that they didn't get back to where they were. They were just independent. So they meet that criteria. It's not that necessarily the surgery and the fixation that's the issue. I think it's the deformity, the healing, the change in alignment, and the impact that it has, especially on an older individual, of being essentially bedridden until you heal, until you can get up and walk. So that's why
Mm.
when we fix it, we do want people to be able to weight bear. So doing like a partial or sometimes even a total hip replacement is a thing. It's a much bigger surgery, so it just depends on the person. We want to get people up and moving, but that time down can be a really big problem for especially older individuals.
Okay, so wow, when you said a third of, so if you get a hip fracture and you get surgery, a third of you can die. Die.
Yeah.
death.
Die.
Do they die from the surgical complication, or they die like blood clot or like pulmonary
Right.
embolus or more the
Right.
immobilization,
Right.
right?
Or pneumonia, UTI, the things that kill people when you lay in bed for more than a couple of days.
Okay, so like pulmonary embolus, urinary tract infection,
Right.
sepsis from the
Right.
UTI, or an infection in the blood. So a third die, a third lose independence, meaning you don't walk the same. We all know about the lurch once you have a hip fracture, right? They walk with a lurch and lean to one side. So when you say independence, can you kind of clarify what that means when they lose their
Yeah.
independence?
Yeah, and this is lost on younger individuals, right? Because as a mid-40s guy, I'm not thinking, oh, something's going to happen where I'm not going to be able to take care of myself. That's usually not in our like in our vision of what's going to happen in our health. But when we mean loss of independence, that means you can't take care of yourself anymore. It means you need to go live in a nursing home or some kind of assisted living facility, or you need some kind of
Mm.
live-in care. It is a very different way of living than most of us young, healthy, productive adults view our life right now.
Does that shorten your lifespan? Has there been a study that looked at hip fracture and the longevity after hip fracture compared to somebody that doesn't
For
have hip
sure.
fracture?
For sure. Yeah, it's hip fracture is a sign that something's been going on for a long time. Now, most hip fractures again do happen in older individuals. So this we have to look at the data. If you're looking at all the people with hip fractures, it'll be biased towards an older population. But even in a younger population, those things still hold true. Where if you're breaking your hip, unless it was truly traumatic, meaning like you got in a car accident and you broke your hip at a high velocity, if you had a fragility fracture medically, it's been wrong for a long time.
Okay, gotcha. All right. So that's pretty striking. But then you also said it's actually worse in men compared to women. Why is that?
Right. I think for two reasons. One is that the average age of hip fracture, it's older in men. So it's an older population to
Mm,
begin with, but they also tend to be sicker because for men to lose enough bone to
mm,
have a hip fracture, again, there's something was wrong for a very long period of time because men start with higher bone density and quality than do
mm.
women on average. So they have more to lose before they get to that point where a hip fracture is going to occur.
Gotcha. Okay. So I always want to kind of dive into what's the consequences. That's why you need to change because if you have a hip fracture, 33% of the time you may die, which is not good. You don't want that against you.
Right.
So yeah, that's pretty bad. And then lose independence, meaning you're going to be in a nursing home or assisted living and not be independent. So we know that the diet, exercise, sleep, and stress of bone health. So, what can men do to preserve their bone density? Because, like you said, men have more density than women to start out with, which is good, but they lose bone density the same way. So, what can they do to preserve their strong bones?
Yeah. So the same concept to preserve bone as it is to rebuild bone. So if somebody's listening to
Mm,
this that has osteoporosis, it's the same thing. You just have a different starting point. So to preserve bone, go back and talk about those four pillars. We don't need to dig into sleep. I think that's relatively obvious. You've probably nailed that home. Same thing with stress. We know that we all need to deal with stress better. Same thing. But when it comes to nutrition and exercise, there's some very specific things here. So from a nutrition perspective, and I don't know anything, Anne, about your thoughts on food. So we'll see if this is consistent with what you say or not. But from a food perspective, if we want to maintain, or especially if we want to build bone, we have to do the same things that we would do if we were going to build muscle. And that's to eat a protein forward diet. My preference is for animals is protein because of compatibility from animal to animal. You need less protein, grams of protein per pound if you're using animal than plant, and there's less potential challenges of consuming that much plant protein. So my preference is animal protein. We start our patients at around 1 gram per pound of ideal body weight. And then we can titrate up or down based off of their individual needs. Some people are significantly higher. Some people don't need quite that much, but 1 gram per pound is our good starting point for us. If as long as you're hitting that, the rest of the diet can be really generally just described as an anti-inflammatory diet that fits your needs. And that could be higher carbohydrate or lower carbohydrate. It just depends on how active you are and what your metabolic function is like. I don't like to get into the details and tell people that they can't eat this or can't eat that. My preference is protein forward from animal sources, fill in the rest as you need, and working with a dietitian probably to help you do that. So that's the diet side. The exercise side is really clear. You can imagine if you want to build muscle, it's going to be the same thing as building bone. If you want to build muscle, what do? You do resistance training. So you need to do high intensity training if you want to maintain bone, if you want to build bone, if you want to maintain muscle or build muscle. Doing that safely in a way that you don't get injured is really important. Most men, at least that I've worked with, are already doing that to some extent, but there's a lot of confusion as to how much cardio should I do and how much time should I spend working on my cardiovascular fitness. What if I want to lose weight? What if I want to get shredded? Whatever it is, we can't let the resistance training go. It's so critical to both muscle and bone. And then the third piece of that is impact. Most people, most humans are not doing impact because it potentially hurts. We run away from things that hurt. So we need impact, though, to stimulate our bone. If you look at athletes that have the best bone density, going to be athletes that have some kind of impact. And I'm not talking running impact. I'm talking like gymnastics impact, right? Like you watch those athletes hit the mat, they're hitting that with some force. Running is not impact. Walking is not impact. We need to generate over 4 multiples of body weight, which is going to be somewhere between 3 and 5 G's of gravity that you need to generate through your bones. And it has to happen quickly. So we need some kind of impact, and that can be from specific exercises or modalities. There's a way to simulate that, but we need something like that in order to really stimulate our bone. But if you can do those 2 things primarily, then you're going to be able to maintain or grow bone almost regardless of your starting point, as long as you have other things optimized as well.
Well, what type of impact are you talking about? Like you said, 3 to 5 G's, but walking is not one of it. I always thought that
No.
walking was effective. You said not even running. What type of activities does that fall
Yeah.
under?
So let me just talk about walking and running first. So when you look at the studies on what impact, quote unquote, impact is as you're walking, it's going to essentially float around 1 G or one amount of gravity, acceleration of gravity. So if you're just standing, that's 1 G. If you're walking, your body is experiencing a range of 0.8 to 1.2. So you're kind of just fluctuating around that 1 G. It's not enough. Running is going to be a little bit higher, but not like you might think, because most people that run are efficient runners and they don't strike the ground very hard. Otherwise, they wouldn't be able to run very long. So if you're an efficient runner, you're not really seeing much impact either. Also, if your body is running a lot, if you're a long distance runner, your brain is telling your body to shed weight, to shed muscle, to shed bone, because it knows that it needs to be lightweight. So runners are strongly associated, long distance especially, with low bone density for other reasons too, dietary in nature. That's what there isn't enough. When I'm talking about impact, some of the simplest things that have been studied would be like a heel drop. So I don't know if you've ever seen people do this, but essentially kind of rise up on your toes and then you drop down on your heels with your knees, maybe a little bit bent. You can generate over 5 multiples of body weight by doing that. And anybody who's sitting at home and thinks that they're going to stand up and do this, please start carefully, because you'll be surprised how much force you can generate when you do that. But force can stimulate bone growth, and you see that in literature. There's also lots of people who are doing different types of jumping exercises. So like box jumps, plyometrics, assisted hanging drops, all these kinds of things that we can help to stimulate. But they have to be done under the right supervision and under the right direction and form. Otherwise, you can definitely hurt yourself. That's why we avoid it in the first place.
Gotcha. What about trampoline?
Yeah, I get this question a lot. Usually people in the osteoporosis community will say the word rebounder, but that's just a little trampoline. And so the rebounding does not show improvement of bone mineral density, which is logical for me, but maybe not for others. Because if you think about what's happening on a trampoline, you're going up and down and you're generating force. Your muscles are firing. That's why it's like it'll make you out of breath, but it's not happening fast enough to be impact. So if you compare it to, say, like whole body vibration, if like the company Power Plate and those devices that move up and down, right? So if you think about how quickly they're moving up and down, 30 to 40 hertz, which is times per second, versus on a trampoline where it's like 1,000, maybe you're getting 2 repetitions in per second if you're doing a small jump. But whole body vibration, which we know does also generate that kind of acceleration in 3 to 5 Gs, 30 to 40 times per second, but only 2 to 3 millimeters. So very small displacement.
Okay, modern man, you are not alone and you don't have to suffer anymore. ED can feel isolating, frustrating, and even defeating. The endless guessing, the quiet shame, the weight of not feeling like yourself is exhausting. But here's the truth. You are not broken. You are not alone. You don't have to figure this out alone anymore. The Get Wood Now Boost program is your step-by-step path to sexual confidence and restoration. No more suffering in silence. No more trial and error. Just real solution, real result, and the confidence you deserve. It's time to take back your power on your terms. Let's get this journey started together. Check out the course at getwoodnow.com. I'll see you there. Okay, so if you're looking to build bone density or a stronger bone, rebounder is probably not the way. Definitely not swimming, right? Because it's no
Nope.
impact. Even walking. Because when I was undergoing training, they said for treatment for osteoporosis, ladies, go walk,
Oh
weight
my
bearing
God.
exercises. So was
Right.
that just a
Can
waste of time?
can we get rid of the term weight bearing exercise? I was actually just prepping for some scripts that I'm recording today, and I was looking at some exercise studies, and they basically said that the control group continued on with weight bearing exercise. And I was like, okay. If we're walking, you're weight bearing. So do we really need to use the term weight bearing exercise? Isn't all exercise weight bearing unless you're talking about swimming? Like, can't we just say walking? So I don't like this idea of weight bearing exercise as a treatment for osteoporosis because we know it's not enough. And so I think, yes, is this a waste of breath? Yes, absolutely. We need to be more specific and we also need to be more aggressive. Doctors just tend to not want to put patients at risk. That's our bias. Let's keep them from fracturing. So we tell them, oh yeah, take calcium, vitamin D, do some weight bearing exercise, and you'll be good. But what they actually mean is take calcium, vitamin D, do some weight bearing exercise, take this drug, and you'll be good. Because it's really the only tool they have.
To clarify, do more high intensity interval exercises, do resistance training, and do more of 3 to 5G impact exercises. And you were talking about the heel lift and plyometric more in a supervised setting. But what is there people to do? What if they're not in a setting where they can be supervised? What
Yeah.
can they do at home?
How to do it. The reason why I'm so careful with the way I say that is that you can hurt yourself if you just walk into your gym and start jumping off of stuff, right? If you walk out to your garage and you start jumping off of your car, like you're going to probably hurt yourself. So you need to learn how to do it. But then once you learn how to do it, you can totally do it at home. So I would recommend if somebody it truly does have osteoporosis, they figure out how to do it. If you don't have osteoporosis and you've been screened, which we need to talk about, but if you don't have it and you're just trying to optimize your bones or maintain bone density, then a lot of these things are probably going to be safe. I would still make sure you know how to do it, but you can do almost all of this at home. You do not need a fancy gym. You don't necessarily need fancy equipment either, but some of the modalities become really helpful, like a power plate, for example, which you can also do at home. It's just an investment.
Right, exactly. So let's talk about how do you have osteoporosis or not?
Yeah. So everybody has heard of usually DEXA is essentially an X-ray that's made specifically for bone density. And this has been around since the mid 1990s. And DEXA looks at your bone density, potentially a software add-on to look at quality, but for the most part, we're talking bone density, but that's only half of the equation of fragility, meaning that when we look at fracture risk, density is only part of the equation. So we're starting out by really only knowing part of the equation for most people anyway, which is a problem. Plus, the other issues with DEXA is that there's quite a bit of variation from scan to scan. Most even manufacturers would say between 4 and 5% variation. They can't tell a change that's less than that, which is a problem because if you look at most of these interventions for bone health, they're usually looking at the like 1-2% change over 12 months. So we can't actually say that any of these tools are going to be effective more so than chance or statistical error. DEXA is a problem. So we need a better imaging mode. Not going to get away from DEXA anytime soon because it's globally available. Everybody has access to one. It's relatively inexpensive, even if your insurance won't pay for it. So we're not going to get away from it, but there are other choices. The other imaging modality that is becoming more so globally than in the US, but it's catching traction here too, is a device from a company called Echolight, and it's a REMS device. REMS is an acronym, but it's basically an ultrasound. So the same ultrasound device that you saw at your wife's OBGYN appointment when they looked at the baby through the belly, same looking thing, just slightly different and has an algorithm behind it that can look at bone. What's great about this device is that it's going to tell you about your bone density, give you a T-score just like a DEXA, but it's also going to tell you about bone quality and then give you a fragility score. This is really important because depending on your bone density and your ethnic background and your height, DEXA can skew people one direction or another based off of the population of interest. So we find, especially for, and this would be for men too, for shorter men that are smaller frame, smaller men, your T scores are probably going to look worse on DEXA than they really are. And if you were to then go get a REMS, your fragility score, I find oftentimes these men have low bone density, but good bone quality. And that's going to change the way that you decide what to do, certainly around drug treatment. If your doctor says, oh my gosh, you have osteoporosis, but your fragility score is good. Now, your doctor doesn't know what that means, but people ask me this all the time. Well, if I have good fragility, I have good bone quality, but my T score is low, what do I do? Well, we still work on it, but maybe we give ourselves a little bit of grace to do this naturally first to make sure we can do this naturally without drugs. There's a time and a place for drugs, but I like to avoid them whenever we can. So that's how we screen. The second part of that is, when do we screen? And again, I would propose, especially if we have access to this ultrasound device, screen every young adult possible, because we need to know our starting point.
All right. And what is the name of the test? REMS.
Yeah, REMS. It's radiographic echo something multispectrometry, but the REMS device is what people call it, and the Echolite, and that's ECHOLITE. So Echolite REMS, and it's an ultrasound device. And when we talk about resources, I'll tell people how they can find this.
Right. Now, is this covered by insurance or not?
No. Not right now. Of course, the company wants it to be, but right now, the people who are buying this device and putting it out there to the public, these are entrepreneurs who have access to one of the franchises that help with bone density, like OsteoStrong and Biodensity. So these owners that have a large population of people with bone health challenges, and they want to have another screening modality. So that's how they're getting out there. But those people are buying a device right now. This device is $70,000 or $80,000. So they need to make money back. This is going to be a cash pay thing for the foreseeable future.
Gotcha. So if you want to get that test done, you would have to go to these facility that has it and then pay cash for it, which is what range? What's the range for the
$200 to $300?
test?
Yeah,
$200 to $300. Okay. Well, $200 to $300 to invest in your health and to know where you're at. It's kind of like the CT coronary scan that I recommend. Calcium coronary scan for cardiovascular health. Insurance doesn't cover that, and it ranges from $100 to $200. It's good to have as a baseline, at least where you start at, so that way where you need to head to. I'm glad we talked about that as an alternative. So what the DEXA is, even though it's covered by insurance, there's a 4% variability in it. So what you're saying is that, let's say if you get a T-score of like 14% and the goal is to increase by 2% or something, the next time you do a test, there's a plus or minus 4%.
We don't know. That's right. So I was just doing a patient example that I'm scripting for today, and fortunately she grew by 20%, right? So in this example, what I'm saying is, look, she had such an improvement, and this is with her spine. She had a 20% improvement in BMD in her spine between her two scans, which were almost 2 years apart. So we can say confidently that this was an actual increase in bone mineral density because it was over that 5% mark. When it's under that 5% mark, we can take a positive, like a 2 or 3% increase. We can take that as a sign that things are probably going well. I don't really know. And that's why this is a long game. So we have to keep scanning, keep testing, keep retesting. I have this framework, and the third R is retest. Make sure you're headed in the right direction, because we can't just choose a modality or choose a supplement or take a drug or whatever and stick our head in the sand. We need to keep finding out if we're improving over time, because 2% plus 2% plus 2%, if you keep getting that 2% improvement, then yes, it's real eventually, but it's going to take 2-3 years or more.
Okay. So that brings me to the next question. Let's kind of backtrack and say, how many years does it take to get to a point of decreased bone density? So there's two terms that it's used by doctor: osteopenia and then osteoporosis. The first part of the question is, how many years does it take to get to osteopenia? And then what is it? And then what is osteoporosis? And then I'll ask you the follow-up question, which is how long does it take to reverse back from osteoporosis?
To reverse osteoporosis, as it were. Yeah, we'll talk about why that's not a great term. So, how long does it take? It depends on your starting point. So, think of it like this: assuming we reach peak bone mineral density for a man, especially like black men have even more dense bones than Caucasian men. Let's use that as an example. So, black male in his early 20s is going to have one of the highest bone densities of any population. If he reaches peak bone mass, then he has a long way to go before he would ever hit osteoporosis, because he has such dense bone that it's going to take a long time for him to get there. So he's got a huge safety margin there. But we don't know what that starting point is for most men. So we can't say that it's going to be how many years is it going to take under what circumstances. We can't really say that unless we know what your starting point is. I also see men that lose bone very quickly. I've thought about guy patients. They have numbers going back for years, I mean decades, where they have T-score after T-score after T-score. And I've seen them lose 5%, 10% over the course of 2 years. It doesn't take long, even if you had a good starting point, if you're losing bone that quickly. We really don't know. And that's why we really do need to screen on a regular basis so that we know what's happening with our bones. Because it's hard. We don't know. And I think because we're not screening for the things that can cause you to lose bone, and some of them are hard to screen for, hard to have a conversation about, we have to use the screening modalities because there's really no other way to know.
Okay, so it can take, if you start out good density, it could take maybe decades. But if you may not start out with good density, you said it could even take a couple of years to decrease the density. So what's osteopenia and what's osteoporosis?
Yeah. So osteoporosis is the medical diagnosis. It's the ICD-10 code that you would use for poor bone quality, and you call it osteoporosis. And it's just defined, it's actually defined by the DEXA, which is kind of annoying because it's not really a good definition. So when the DEXA was brought forward in the mid 90s, there had to be an objective criteria that could be used for pharmacologic recommendations. So this is how this whole system's tied together. So a T-score of negative 2.5, meaning 2.5 standard deviations below the mean for sex and ethnicity, is the definition of osteoporosis. But every manufacturer has a different database. Every ethnicity is different, gender is different. So it gets really confusing really fast. But in general, that's the major criteria to the T-score across everybody. Unfortunately, like I said earlier, people that are at the extremes of the bell curve are going to probably not be accurately. We see this in our thin Caucasian and Asian women that have a smaller bone frame. They will generally come out with a lower T-score. Generally, they're just comparing it to kind of like the wrong bell curve, if you will. So osteoporosis is the diagnosis. Now, osteopenia is a term that was coined to be somewhere in between what they consider -1 to -2.5 on that scale of T-score. But it's not a diagnosis. And I hear this all the time, and it's really frustrating, is people will say, oh my gosh, I got diagnosed with osteopenia and my doctor recommended that I go on a drug. It's a little crazy because osteopenia, A, is not a diagnosis. There's no ICD code for that. And B, the recommendations for drug therapy generally should not include people with osteopenia unless they're rapidly losing bone for another reason. So I hear this all the time, and I think this is a misunderstanding from doctors and a reason why they actually are changing that term. So osteopenia is a term that needs to go away. We need to stop using that term, and we just want to call it low bone density. So we're going to say you have low bone density. And then if you have low enough bone density, then you have osteoporosis. We need to get rid of the term osteopenia because I think people they look at them as the same thing, and they're not. Osteopenia might not be an issue at all. For example, I have osteopenia. I've had osteopenia my entire life. My T-score is about -1.1. So I meet the diagnostic criteria, if there were any, for low bone mass. I have osteopenia. But I know that it's been that way since my early adult life because I had a DEXA done. I was a research participant in a study, and they did DEXA. I did DEXA body comp, but they had a T-score on there, and I know that I had low bone density then. I think it was because of my diet growing up and lack of activity, and that's a whole other conversation. So should I go on a drug because I have osteopenia? Of course not. My bone is getting more dense. It's getting stronger as I age, which is why I say we don't have to accept that bone loss is a part of it. Age is a part of it because we prove that wrong over and over and over again. So I hope that helps to explain it. Osteopenia needs to go away. Low bone mass is lower than 1 standard deviation. Osteoporosis is lower than 2.5 standard deviations.
Okay, so then can we reverse it? You said, no, you can't
Yeah.
reverse it. Let's clarify that. So what can we do? Or you're SOL.
So most doctors will tell a patient when they get a diagnosis of osteoporosis that they cannot reverse it. Just like so many chronic
Mm,
diseases that you and I are trained on, and diabetes, the same thing. I was trained diabetes is a progressive disease. You'll only get worse, take more drugs, then you're going to go on insulin, then you're going to get your legs cut off, and then you're going to die. That was sort of what I was trained with diabetes, because I had a leg cutting off thing. Osteoporosis is viewed the same way. You're not going to reverse this thing. The only thing we can do is slow down bone loss and
mm, mm,
hopefully prevent a fracture over time. And we're going to have to use these drugs. That's the way that we're
mm.
trained around this. As an orthopedic surgeon, that was my understanding of the disease. But what I can tell you now, we've been running a program where we help people reverse osteoporosis naturally for the last 4 years. We've been dialing it in. And what I can tell you is that if you have the ability to eat the diet, do the exercise, optimize hormones, especially, but not always, but if you can do those three things, the vast majority of our patients are seeing improvement in bone turnover markers and imaging within 12 months. I really look forward to getting data on the 24-month and 36-month follow-ups, because what we're seeing is like that case I shared earlier. We're seeing these massive increases in bone mineral density, 10, 15, 20%. And this is all through diet, lifestyle, and hormones if people are candidates for hormones. You can do it without hormones too. It's just slower. So absolutely it can be reversed if you have the capacity to do things that we need to do, which is exercise, the sleep, the right diet, and then optimizing hormones helps. So absolutely it's reversible, and I can't say that loud enough.
Okay, so that's good to know. So what hormone are you talking about that is effective?
Yeah, so most of our patients are women. So we're talking replacement therapy for women. That's estrogen, progesterone, testosterone is if needed. For men, we're much easier. For men, we're just talking about T. We're talking about testosterone because we don't make estrogen outside of our testosterone. So we just need to optimize our testosterone. Not really talking about thyroid here, but if we optimize our testosterone, you're going to have optimized estradiol. The balance between those two hormones is going to be more than enough to keep your bone healthy and keep the stimulus to turn over bone going. Low testosterone, talk about this enough. Subclinical low testosterone is a problem, even if it doesn't lead to sexual dysfunction yet. And this is a big takeaway for your audience, which is that for guys that have like maybe it's a little different, maybe my performance isn't as good, your bones are going to tell you before your penis is going to tell you that something's wrong with your hormones. So we can cut that short and we can prevent that from happening by looking at hormones earlier.
Okay, great. So that's what I was going to ask you. What's the connection of bone and the sex? It's the hormone, but it's also, you said the diet and of course, eating clean and more high protein and the exercise, all that increases testosterone. And then all that also decrease inflammation, which then is also improved cardiovascular health or blood vessel health, which for sexual health, that's the pivotal change that you need to get more blood flow to the penis for that's where the connection between the bone health and then the sexual health. So but what you did said earlier, I wanted to clarify, was that you said that the bone changes may show up even earlier than the
Mhm.
sexual change.
Yeah, so let me clarify that. So what I mean is that if you were bone quality and density, let's say using that REMS device. So if you're looking at an ultrasound of the bone and you look at it over the course of a couple of years and you're losing bone, I would want to know a lot of things, but one of those things is I want to know what's happening with your hormones. That's going to happen before you would reach a point where you would have the clinical manifestation or you would notice erectile dysfunction or decreased performance, decreased libido, et cetera. Because I have lots of patients that have moderate testosterone. They have low estradiol because they don't have enough testosterone, but they don't have any symptoms, or at least they're not telling me that they have any symptoms of erectile dysfunction or low libido. So your bones are going to tell you before your penis tells you.
That's very interesting to know. Now I wonder whether I need to order the REM, the Echo REM test that correspond with my workup as well. Haven't thought about that, but that makes sense to me as in hormonal health, because when we do blood work, we look at thyroid and prolactin and the
Yep.
hypothalamus hormone as well. So why not check that? Very interesting. So any last minute tips that you can give to our audience after this very insightful episode.
Mhm.
And I have to tell, I've learned something as well too. So I
Yeah.
hope that our
Yeah. Right.
listeners have some takeaway from this. But what advice can you give to our listeners at this point and how they can take care of their bones as they
Yeah.
age?
Yeah, this is one of those areas in healthcare that's tough for men because as men, we generally don't ask for help. We generally don't pursue things that aren't put in front of us. It's just how we're wired. And that's not wrong. It's just who we are. And that's okay. So, what we need to do is understand that the things that I just talked about are relevant. They're important. They're going to have an impact on your lifestyle, on your lifespan, on your health span. I would encourage you to know what's happening with your bones, add things that you want to check on a regular basis. If your doctor cares about cholesterol, fine. Let's add bone mineral density and bone quality to that list as well, and then track it over time. You've got to be an advocate for yourself here because your doctor is not going to talk to you about your bone health. But if you use this as a tool, it'll help you to know if something is with your diet, with your lifestyle, with your hormones, and it can help you to put together that big picture. So that's the big takeaway here.
Well, yeah, that's good to know. And then one point I wanted to kind of, a minor point I want to find out is that estrogen, men also need estrogen too. Estrogen is
Absolutely.
just not for women, even though men have a lot higher testosterone than women. But estrogen actually plays a role also in your bone health, but it also plays a role in your libido,
Yeah.
desire. Estrogen
Hmm.
is important for that. So it's important to keep it in kind of somewhat above 30 level on the blood test. 30, I try to keep it around 30 to 60 level. So
Yeah.
it's good to have some estrogen, but not too good to have too much estrogen. So that's the beauty of being in clinical practice, is to be able to see patient and be able to customize the treatment plans. And I'm sure that's what you do all the time in your
That's right.
program
Yeah.
with your patients. So tell our viewers how they can find out about your program and how to work with you.
Yeah, so we have two types of programs. So one is comprehensive bone health program, which is if you have osteoporosis and you want to reverse this naturally, then this is the way to do it because this is the lifestyle optimization. We look at the diet, we look at gut health, we do all the things, and it really works. But it's work. So if you want to work with somebody to do it, that program is the company called Optimal Human Health, and that's optimalhumanhealth.com. Lots of information on that website. That's the way to get help to do it for us to kind of hold your hand as we walk you through. But what we found is that so many people, if they just have the right information, can do this on their own. So, yes, I love the practice. And yes, we're helping people and we kind of sort of run at capacity. But the community is where we put as much information as possible at the fingertips of people that want to improve their bone health or learn about hormone health. We have a lot of that content there too. So that's called the OsteoCollective, and the website for that is just OsteoCollective.com. And this is a low cost monthly membership where you can go in. There's weekly Q&As, there's research libraries, there's all the material that you could ever need to learn how to improve your bone health and all the resources to do it. You can get labs through there. You can actually potentially work with our nutritionist to do gut health and or do all these things. So the Osteo Collective is the way where most people I view in the future are going to get this information and do it themselves because they don't necessarily need the full program. You have both options for people that need each one.
Okay, great. So there's two type of program. One is more in a group, and the other one is a little bit more intensive, which is the other one, the optimum. Okay, great. So I believe you have an ebook for our audience as
I
well. That's
do.
something that they can
Yeah, it's
get.
hidden behind my head here for those watching this on video. Yeah, so the osteoporosis breakthrough is an ebook that we're happy to give all your listeners. So we'll make sure you have that link and you can download the ebook. I go through in here some of the big players that we didn't get to today about the confusion and the myths and mistakes that we see people with that are going through the bone health journey. So it's a quick read, easy enough to read through an ebook. So happy to give that to all your listeners.
Oh, great. So we'll put that link in the description. So make sure that you check out the prescription for the episode. So having said that, thank you, Dr. Doug, for your time and your expertise and teaching us about the connection between bone health and your sex life and why men, you need to know about this because you will have osteoporosis too if you don't take care of your bone. Okay, modern man, you are not alone and you don't have to suffer anymore. ED can feel isolating, frustrating, and even defeating. The endless guessing, The quiet shame, the weight of not feeling like yourself. It's exhausting, but here's the truth. You are not broken. You are not alone. You don't have to figure this out alone anymore. The Get Wood Now Boost program is your step-by-step path to sexual confidence and restoration. No more suffering in silence. No more trial and error. Just real solution, real result, and the confidence you deserve. It's time to take back your power on your term. Let's get this journey started together. Check out the course at getwoodnow.com. I'll see you there.